Okay, I'm Ian Ord, I'm a GP in Stratford-on-Avon. I'm one of the governing body GPs on the CCG governing body. I was involved with the Over 75s project, which the CCG commissioned last year. The project was to focus on the over 75s age group, and the CCG worked with GP practices in the area and with Age UK to work proactively with this group of our patients, and to look at their needs and to try and improve their quality of life, and also to reduce unnecessary admissions to hospital. Yeah, so the project enabled us to reduce unnecessary admissions to hospital. We know that a lot of older people would much prefer to be looked after at home, and we can do that, and we're able to do it with this project by identifying the patients, by focusing on their wishes and priorities, and also by preventing some problems which might have resulted in them being admitted to hospital.
So, hello, my name's Christine Lewington. I'm the Head of Strategic Commissioning for the People Group within Warwickshire County Council. And I work very closely with South Warwickshire Clinical Commissioning Group, and particularly their senior management team, so Sue Phillips, Anna Hargrave, Alison Walsh, Jill Entwistle, to name just a few. I think overall we have a very good and strong relationship. I think there's good partnership working over many years, and that's gone from strength to strength. And that's particularly relevant in terms of Warwickshire Care's Better Together, which, as you know, is a Better Care Fund initiative. It's a national initiative, but I think before even then we were establishing quite a strong partnership role, working together on lots of different initiatives that culminated in the Better Together being so successful here in Warwickshire. The partnership is extended then to include some of our providers, so we have a good working relationship with our providers, and we recognise some of the challenges but also the opportunities within those wider partnerships with our providers, which I think helps us to be a strong health and care system that has the opportunity to really grow and strengthen our roles as we face some of the more efficient, more of the challenges that we've got around some of our savings programmes and efficiencies that we all need to make up to 2020. So through the Warwickshire Care's Better Together programme, particularly because that acted very much as a sort of framework for our joint work, both with between ourselves, South Warwickshire CCG and the Council, and our wider partner. We have done some really innovative initiatives, not least with primary care and the GP federations, and social care is beginning to become part of that, which I think is a real major step forward, and it's one that will create a real opportunity for us over the next few years. We've also done a lot of work around some of our joint initiatives. So, for example, we now, I think, have a very strong integrated commissioning and equipment service. We have a board that has all the relevant partners on, and we have a real grip on what we call our ISIS provision, with 7-day service and next day provision, which I think is again a real positive and supports what we're all working towards, which is about helping people to remain at home as independent for as long as they possibly can. Coupled with that, we again working with our health partners, we have developed our redesign for domiciliary care, and that's been really important that our health colleagues understand what that redesign involves. It means that we have stripped out some of the providers to become much more focused and much more localised, so people can have that relationship with their home care providers, and hopefully that we have a much more speedier response, and that will support both our admission avoidance initiatives, but also improve our delayed transfers of care. So that's about access to packages of care. We're just bedding that down. But the crucial part of that is that we work together to redesign and to award these contracts to the new providers, which is coming live which has come live actually on the 1st of August. So very, very new initiative. Again, we've worked together with our health colleagues also in our redesign and outcome-based process for residential and nursing care. That's an ongoing initiative, but the strength of the partnership has meant that we're able to go out collectively and together to our residential nursing care providers to say, these are the fair prices for care, but this is the quality that we expect moving forward. We're still going through that process, but again, I think the strength of our unity will play out in terms of how we manage the residential nursing care market as we move forward. We've still a lot of work to do, but we can't do that in isolation.
Hi, I'm Dr. Richard Lambert. I'm a GP in Ulster at the Arrow Surgery, but I've also been a prescribing lead for a number of years in South Warwickshire, going back to the days of PCT. There's two main parts to prescribing in South Warwickshire. There's primary care prescribing, which is the prescribing that is done largely by GPs, and that includes most of the prescriptions that patients will collect from their practice and take to the local pharmacist. And there's what we call high-cost drug prescribing, which is usually secondary care prescribing. So those are drugs that are prescribed by consultants and are largely administered and run through hospital. But then the value of those drug costs are then passed back to the CCG. In between those two things, there is also a group called the Area Prescribing Committee, which we're involved with, which looks at the interface between new drugs that are coming out in secondary care and how they might impact on primary care, and which drugs should be used in primary care and which in secondary care, and which can be transferred across those two areas. So if we start with primary care prescribing, we've traditionally always had quite a low cost, high quality prescribing in South Warwickshire. So we start off from a good base, and that we are prescribing at a level that's below the national average and below the average for our peers. And last year although we saw an increase in the volume of prescribing and the cost of prescribing, the percentage rises were roughly half what you'd have expected based on national figures. The sort of work we undertake in medicines management is support to practices, so that can be as little as an annual report that's sent to a practice for comment, through to an annual meeting or more regular meetings. And last year we had a scheme going with our most overspent practices, which involved actually embedding pharmacists within the practice employed by the CCG to help practices in dealing with their prescribing levels. On top of that, we have a prescribing incentive scheme which has been running for a number of years, and that's roughly divided into two halves. One half is a purely financial target, so practices are underspent, they receive a small amount of money to spend on patient care in their practice. If they're overspent, they don't. But the other 50% is usually looking at areas of quality prescribing. So we've looked at areas such as diabetes prescribing, we've looked at anti-inflammatory and antibiotic prescribing. We've done work on de-prescribing, that's stopping prescriptions for patients who don't necessarily need them, or where drugs may actually be causing more harm than good. And that isn't dependent on financial results, that's just depends on practices doing audit work and doing making changes on their own right. If we look at high cost drug prescribing, that involves working with the hospital, and there's sort of two strands to that really. One is again looking at the actual volume and making sure that what we pay for is actually what has been delivered, and reconciling invoices with payments. And then the other part of it has been looking at dealing with pathways within the hospital, working with consultants at the hospital to develop pathways that actually show where and what drugs should be used at what point in a patient's illness, and really to make sure that what we're doing is actually of benefit to patients, and also that we can demonstrate that we're getting full value for money for what we're paying for.
I'm Ollie Lawton. I'm a partner at Clarendon Lodge Medical Practice in Leamington Spa. I took the role as lead for a project looking at the service we offered to our residential home patients. That was funded by the Innovation Fund from the CCG in the financial year 2014-15, and we finished the project about 3 months ago. Yeah, so there's been several outcomes we measured. The most important one and the sort of headline figures were about reducing unplanned admissions to hospital. We got those numbers down by about 50% amongst our cohorts. We also looked at reducing prescribing costs and worked out an annualised saving of about £32,000, which worked out roughly at £260 per patient across the patch. There were a number of outcomes we measured, and the quantitative things we mentioned with the savings, but the qualitative stuff really was feedback from the patients and the care staff and the patient's family. We found that families, patients really appreciate having a single point of access at the practice. In our practice, that was me as the GP, and we also have a community liaison nurse who worked brilliantly in communication with the homes. That just offered them somebody to come to that they knew their mum or dad. We knew their mum or dad's preferences, whether that was for hospital admission, ceiling of care, preferences and planning for end-of-life care. And that just was a really rewarding part from our point as well. And I think the families appreciated that. So the initial involvement from the CCG was in the form of the funding through the Innovation Fund. We applied to them, said we have this idea, we would like to offer this to our patients, and they costed it and allowed us to run the project financially. As the project went on, we had regular meetings with a representative from the CCG, and really the project evolved from there. I think we all felt about 6 months into the 12-month project, it felt more like a feasibility study rather than a one-off project to see what the outcomes were. Ongoing, the CCG have felt that because of the successes of the project, it would be a good idea to offer this to the whole of the residential homes across the CCG.
I'm Alison Walsh, I'm Director of Quality and Governance and Executive Nurse for South Warwickshire CCG. As a CCG, we pride ourselves on the work we do to improve quality. Our focus during 2015-16 has been on quality in primary care, i.e. GP practices, and in care homes. We took on delegated responsibility for GP commissioning from NHS England in April 2015, and as part of that we developed a new contract management and quality improvement framework in support of the aim of reducing variation in quality between our practices, but also raising the overall quality of services for patients. The Care Quality Commission is currently in the process of inspecting GP practices in South Warwickshire, and we're delighted that of the 15 practices so far inspected, 4 have been rated as outstanding and 11 have been rated as good. Feedback from patients completing the National GP Survey has also been very positive. A further focus, as I've said, has been on raising the standard of care in care homes, and in that regard we've appointed an infection prevention and control nurse whose key aim is to educate staff on good infection prevention and control, including importantly the management of outbreaks. That certainly paid dividends last winter, where more residents who had got infections were managed in the care home setting rather than being admitted to hospital, and that certainly helped our A&E performance and the flow of emergency patients through the hospital setting. We remain one of only a few hospitals now nationally that are still achieving the A&E 4-hour wait target. We continue to work with our major NHS providers, both South Warwickshire NHS Foundation Trust and Coventry and Warwickshire Partnership Trust, to improve standards of care for our residents. During 2015-16, we instigated clinically led quality liaison meetings with the Partnership Trust in particular, because we don't commission their services as the lead commissioner, and that's to ensure that the specific needs of South Warwickshire patients are effectively recognised and addressed through service developments and improvements. One example of this is a new scheme that will go live with some practices during the autumn to actually diagnose and manage patients with dementia in the primary care setting. We're hopeful that if that's successful, we'll roll it out to further practices as we move into next year.